Dear Pure Urology viewers, good evening one and all. Yesterday we have done one supine versus prone. There is some issue in the voice. We wanted to do the same program again because a lot of requests were there. Apologize for that because it was cell phone recorded. Coming to the today topic, a very interesting topic today, that is suction during RIRS. Honestly, Dr. Speaker today is Dr. Parimal Gharia. Recently, he has gone in depth about this suction. He first used this suction directly through the scope without any company's help. It is his thought that everybody might have thought, but he posted. Is the person who writes the paper first will be named. The person who posts will be named. Like that, in the Twitter, he posted with the aspiration with the syringe, with a Y connector initially. Then powder will come at the bottom of this thing. After that, the accessory suction suddenly has come into picture. In both the ways, he has done a lot of research and he is doing every case. Pros and cons also he knows very well. So let us share about the speaker today. I will briefly introduce about him. Before I say about him, he is a close friend of me now, irrespective of the age, because he is also running one WhatsApp group, Euromentarium. Anybody is interested can contact him. I am also in that group. Phenomenal amount of information about the equipment unbiased, and it is conducted very well without any other discussion. How the instruments work, what instrument is better, how much cost effective they are. Openly we will discuss, not related to any company. That is the best part of Parimal. He is gaining popularity in that and he is knowledgeable also. So today he is speaking about what I learned fan suction in RIRS recently. I must remove the recently word because already years have gone. So he is consultant urologist and laparoscopic surgeon. He is the director, Icon Hospital, Surat, Gujarat, India. Achievements: among the pioneer use of suction in RIRS, as I mentioned, own technique of intrascope suction, as I already mentioned, is the first person in India, one of the persons missed, that is manual intrascope suction technique. That is very easy, no cost involved. Even I tried. Only thing is that you need patience. That's the problem. Fans, early users of fans, then he now I think he is using fans also. Armamentarium and gadgets in urology is known. He has given multiple. This is a topic, very sensitive issue. Not many people can speak well unless you have knowledge, upgradation, whether it is caught. Recently, I have taken a CM after the discussion in the group. Even I could not do that much discussion in pure urology as much as Euromentarium group is happening. So his faculty and national international conferences. With this introduction, Parimal, I am very happy that you are growing and your videos and your Twitter posts are posted by the international faculty. Many of them, even in papers also it is addressed. I mean, published papers also it is addressed. With this background, you enlighten us where it is useful, what are the problems, honestly you share, so that a lot of people are interested in suction now in RIRS. Thank you. Over to you.
Thank you, sir. Thank you to inviting me for a pure urology. I will share my screen now. So I'm thankful to Dr. Chandramohan Vaddi sir for inviting me for the third time, and that is all related to RIRS. First was the suction in RIRS, then the flexible, the baskets and everything, and now we are talking about the fan seat. I declare no conflict of interest. We all know that the pylorenal backflow is a preservative system when there is a high pressure in the pelvic LSL system, and it is also related to infection causes during RIRS. And intrarenal temperature is all about the fluid that is going in and coming out. So ultimately, what are the Achilles heel of RIRS at present? First is high intrarenal pressure associated Europe sepsis, perinephric and subcapsular collections, high intrarenal temperature, poor vision during lasing, and residual calculi which requires multiple procedures. So we all know that as soon as we start lasing, there is a lot of dust floating all around, compromising our vision. We have to pedal on and pedal off we have to stop, allow dust to settle, and then again do it. So it ultimately increases the operative time. Second thing was the problems with the residual stones. The residual stones are difficult. What happens is whenever there is a large stone we are doing, there is a lot of dust in PC system which hides these residual stones. So these larger fragments are left behind and ultimately produces the residual stones. Many a times it requires additional accessories like baskets, gadgets, and everything to pull out these residual stones. And sometimes when you require to be 100% clearance of the dust, these are the small, very minor particles that cannot be even basketed also. So ultimately, when you do a CT scan, this all compromises our stone-free rate. All discussed things now is all about inflow and outflow mismatch. If there is an inflow is only from irrigation from the scope and outflow is through the sheath or through the ureter. So it should work like a continuous flow Iglesias system. Whenever this system is disturbed, there is a high intrarenal pressure and associated complications. So possible solution to this was thought of is decreasing the irrigation, but it will ultimately decreases the vision. Increases the irrigation, it increases the IRP. So the only option we are left with is to increase the outflow, that is suction in RIRS. The suction techniques were through the scope and through the sheath, or outside the scope. Multiple attempts were done to progress in this field, and ultimately what I thought was already you have described is a manual intrascope suction, that just attaching a 10 centimeter suction syringe and aspirating the dust, that ultimately produces results. But what has happened is it issues the resolve issues where the intrarenal pressure and temperature were decreased, intermittent good vision was achieved, and ultimately the smaller fragments which were left behind in the heap of the dust were also been visible now, and we were able to fragment it into a minor fragments and increasing the overall stone free rate and decreases our complication rate in RIRS. But these all benefits were almost intangible or unmeasurable with intrascope sections, and it has its own limitation of channel clogging, intermittency, manual, and the biggest problem with this was the reproducibility. What I found is reproducibility of this system was not that much. So still the balance of all things we combine, the PCNL was still the balance was high because of on-table clearance, uncertainty about, even if we have fragmented well, we were uncertain about how much days it will take and how much clearance we will achieve, and ultimately will require multiple procedure or gadgets for residual stones. So PCNL was still, when before the fans came, the PCNL was still a heavyweight, a competitor compared to an RIRS. But what has happened is the Clearpetra has extended his PCNL sheath to a ureteral access sheath, and they have made a non-bendable or a simple suction sheath just by attaching the Y connector at the end of the sheath. What we achieved is we achieved a continuous flow receptoscope like system. So there is an inflow from the scope and outflow from the scope. So these were the initial system that the scope was attached, a suction was attached to a Y limb, and the suction was done. Initially, a few good results were produced. You can see this is a system of bendable suction access sheath or non-bendable access sheath. You can attach a cap at the blue cap, and then attach a suction that is attached to a stone collecting bottle, and then now stone collecting bottle is attached to a regular suction what is we use in the OT. So ultimately, and there is an on-off mechanism at this place. So ultimately, whenever you wanted to completely stop suction, you can do it, and there is a knob or a hole is there. Whenever you do not want to suction, you can keep that hole open and the suction will not happen. Many people ask it, what suction is used? The suction what is used is a routine suction what we have available in the OT. There is no, and the pressure I start with the 150 and ultimately go to 230. So this was the non-bendable access sheath used for an upper ureteric sting. You can see that the continuous flow was achieved and the continuous lacing was done during whole the procedure, and the complete stone clearance was achieved by this mechanism. But then a company thought that this sheath should go above the PUJ, so they added a 10 centimeter flexometallic part, that is non-collapsible part in front of this seat, non-bendable seat. Now it is converted to bendable seat, and this bendable seat is, now you can see that is bendable seat is can be deflected by the scope mechanism. So ultimately it becomes a fans, or we what call is the flexible ureteral access seat. This seat is now at crossing the UPJ and touching the mucosa of PC system. So the seat was made like that the further 2 millimeter or 3 millimeter part is a flexible, and whenever it touches the mucosa of PC system, it does not cause damage and does not cause bleed. So ultimately this fence was conceptualized and then one was used. So now the flexible, you can see that the flexible seat is across the UPJ. We are reaching to the stone with the scope and the seat, and then we are fragmenting in front of us. So what was achieved was a continuous flow reset, continuous flow inflow outflow, not in the ureter. Now it has gone up to the PC system. You can see there is a difference. There is a difference between a seat inner diameter and the scope outer diameter. There is a gap in between, and the stone direction. So ultimately the concept of this was just to have a continuous flow, inflow, outflow in the PC system, just by decreasing the intrarenal pressure and intrarenal temperature and removing the dust, so that the continuous lasing can be done. So what has happened is, then now we have started using this seat. At one point of time, we have now observed that it just does not only remove the dust, but it can attach the fragments also. This fragmentation, the retrieval of the fragment, this retrieval of the fragment is done by the mechanism what we call as a vacuum cleaner effect. So now the people who are early user of the system has realized that it can remove the fragments. So the concept has extended from the continuous flow to now removing of the fragments. So the concept has changed. The vacuum cleaner effect is when you remove the seat to the Y junction, the fragments go to the Y part, and the scope is again then reintroduced. This was vacuum cleaner effect was already described in the PCNL. Now it has conceptualized into the flexible access seat. So you can see there the multiple fragments can be removed by vacuum cleaner effect. Either it can be a small fragments or it can be a larger fragments also. The larger fragments can also be sucked by these mechanisms. So ultimately all fragments what are left in the PC system all were removed at the end of the surgery. So earlier access seat was 11-13 diameter and it was too large for Indian ureter. For the 3 months, I could do only 3 cases of flexible ureter sub with 11-13 seats. So then there comes with a demand for a 10 French or a 12 French ureter access seat, and it was used by me. And what I described the ureter access seat or a fence is just removing the fragment by reaching with the seat to the fragments, and all the fragments are ultimately sucked out. So all the advantage of suction ureteral seat plus this stone fragment or a stone on table stone clearance were achieved. Stone analysis for almost all patients is achieved, which was lacking in the traditional RIRS. But what happens is the story of Indian ureter. We can see that the stalwarts are saying that there is the Indian ureters are small, and we all know this, the picture of using an access seat and the grade of injury of ureter by access seat. So ultimately what happens is, what most of the people in India were using a primary RIRS because of so many reasons, because patients are not favoring multiple stages. Most of the patients are spending out of pockets. Technological advancement has done possible to do a primary RIRS into 90-95% cases. But what happens is, when you do a primary RIRS, 5 to 10% will fail. Then we do a proper RIRS, and ultimately it will be relook RIRS. So ultimately for RIRS, we need to explain to a 2 or ultimately 3 procedures sometimes. But what has changed after the fence? Because I consider RIRS fence as a practice changing innovation, and I will try to narrate few areas where it has made a change. The first thing it has made its change is the on-table stone clearance, which was never achieved in RIRS. It was first achieved by fence. Second thing is tubeless RIRS. Whenever I do a pre-stenting and I do RIRS at the second stage, most of the cases I will try not to put a stent. So more than 50% patients I could do a tubeless RIRS without even a Foley's catheter, and patient is absolutely comfortable without any complication with 3 months and 6 months follow-up. Third is a liberal use of pre-stenting. When you are certain or almost certain that on the second stage you are removing all the stones, then you are confident of doing a pre-stenting, and you use a pre-stenting liberally without forcing your ureteroscope through the tight ureter and damaging the ureter. So the safety of procedure has already increased. The particle size which can be suctioned by a 10-12 sheath or an 11-13 sheath were different. But what happened is, on a study by Dr. Gohar, what we found out is 10-12 sheath has a better stone clearance rate compared to a 11-13 sheath, and only explanation of this is a vacuum cleaner effect that has produced the stone removal or a dust removal at the end of the surgery. So ultimately 10-12 was a good scientifically also. So we have now come to a 10-12 sheaths. You can see that the another problem was a residual stone at the check RIRS. Whenever we do a primary RIRS and when we do a check RIRS, we find a multiple fragments. It was a tedious job to store small stone by basketing or whatever method. With this already pre-stented patient at the primary surgery, and you remove all the fragments at the check RIRS, and you are 100% stone free, and you are confident. No imaging also is needed for that. Another is last month I tried 3 to 4 patients. What I do is, whenever I think that a stone is very large or the duration of the surgery may be longer, in that case is what I have done is, I have done a conventional RIRS, and at the end of the procedure, toward the last 15-20 minutes, I introduce the ureteral access sheath fans and remove all the fragments, and on-table stone clearance was achieved. Another issue was a hydronephrotic kidney. We were afraid of doing a RIRS in hydronephrotic kidneys because the fragmentation was difficult. Dusting to a small, very small particles was difficult, and we were also concerned about the clearance of these small stones. So ultimately, in hydronephrotic kidney, PCNL became the first choice, but ultimately with fans, the hydronephrotic kidneys can also undergo RIRS and we can remove the stones. Previously, there are multiple stone. Whenever you see there is a single pelvic stone and there are multiple hundreds of small stones in any cheilitis secondary calculi, we were afraid of doing an RIRS because it was very tedious to remove these small fragments. Now with the fans, all the secondary stones can be removed or suction out without using a basket, and we can have a complete clearance in these patients also. So the kidneys with multiple secondary calculi is now not a contraindication for RIRS. Small kidneys. We were afraid of doing PCLN in a small kidneys. We were afraid of doing RIRS in a small kidneys because we were afraid of a small space, high intrarenal pressure, chances of injury or a rupture of the kidney. So in that cases, the RIRS with the fans or RIRS with the suction is absolutely helpful. I have done many cases of small kidney RIRS and they are good. Even with the less GFR also, it can be sucked out. Another problem was, whenever we do a pre-stenting and we go in during an RIRS and we find a matrix or a material out in and around the stone, we were afraid of doing RIRS and we were converting these patients to a PCNL or a mini perc with the suction. But now with the ureteral access sheath, you can, with the fans, you can remove all the matrix around the stone and do a safe RIRS in these cases also. Bilateral stones, solitary kidneys, all can be done with the fans, with pre-stenting or without pre-stenting also. Now what has happened is, we can do a primer by this was a study by Dr. Anil Shrestha and group from the Nepal. What they have found is that even a 10-12 sheath, a standard 10-12 sheath can access the ureter in 67% of cases. So 2/3 of cases, a primary RIRS with 10-12 sheath that is not crossing the UPJ was possible. So I extended this concept to a primary RIRS, and I am able to do a primary RIRS in around 30% of cases. Primary RIRS without pre-stenting, and still these patients are producing a good results without a significant complications. Now the significant change what the fans has come is, you don't require a fine dusting. The fine dusting concept will go in a period of time. So there is no discussion, there should be no discussion about holmium or TFL or whatever laser or what power of laser you have. It will change everything within no time. Second thing is, skill requirement will also go down. Previously, the good RIRS surgeon were considered to be a who produces a very small dust or a very fine dust. But that fine dust is now not required. So many people will adapt to this because of the skill requirement of RIRS will go down, and you can remove the relatively smaller particles also. Still, we will not be able to reach a 10 to 15% of calcium, specifically the lower calcium or the difficult calcium, and this still remains a Achilles heel of fans also, that you are not able to drive your scope or a seat into the lower calcium, and that becomes there. In that cases, I added a manual intrascope suction so that these stones can be dusted in situ and dust can be aspirated from this system, and then a fans can be used. Tight ureter, tight UPJ, infundibular stenosis, all can be a relative contraindications of flexible ureteral access sheath or a fans. But with these fans, we see that the flexible sheath is required to be bent by a force of the scope. So all delicate scopes, all single-use scopes, the scope durability is and will be a issue in a time. Second problem is sheath durability. Sheath doesn't last very long, so it ultimately adds to the cost, but it can ultimately decreases the overall inventory in your hospital, that you do not require high power laser, you do not require multiple stages, so ultimately it compensates for at some places. And another problem of this sheath is these are the longer sheaths. These are around about 45-50 centimeter sheath what you are using. So even if we are stuck that your sheath doesn't cross to the UPJ or it keeps in upper ureter, your sheath will remain, lot of part of your sheath will remain outside, and your RIRS with the small scopes and the will have some problems in reaching the desired calyx. Second thing is, we are with these sheaths, we are losing the advantage of secondary reflections of the scopes. What we are doing is we are crossing the UPJ and putting the sheath up. Now, in a difficult scenarios, when we want to use that secondary deflection mechanism, specifically in the large hydronephrotic kidneys, ADPKD kidneys, then that advantage of secondary deflection is going. In that cases, you need to withdraw your sheath below the upper UPJ into the upper ureter, and then only then you can use just like a standard ureteral access sheath or a standard RIRS. Second thing I found a problem is a scope bendability. Whenever you do a vacuum cleaner effect, you come out and you try to go, the most flexible part of the scope is bent at the tip. So ultimately it may affect the scope durability if you are using a reusable scopes. Secondary things is we are straining the UPJ by going into lower calyx. We are straining the UPJ on a lateral aspect, and this is remain still a, though we have a early good results, this remains to be seen that what happens over a period of time, 6 months, year, 1 year, or 5 years down the line. Another problem what I faced was a stuck fragments. I have done a large stones and suboptimally fragmented, and then actually it always stuck come out and it impacted into the sheath. Now it takes around about 40 minutes to pass these stones by lasing and ultimately sacrificing this sheath. So it's sometimes suboptimal fragmentation and try to aspirate the larger fragments may cause these stone struck fragments into the wall of the sheath, and it may cause the stuck sheath. UPJ injury is and will remain a major cause of concern. Second thing is mucosal bleeding. If you do a negative suction too much, there can be a mucosal bleeding. Many people are using active irrigation because the suction is sucking out a lot of fluid. Now we want to do a compensate for this by doing an active irrigation. I think we should avoid doing active irrigation in this, even with the suction, because it is just like a reversing the clock. Studies have found that over a period of 3 months, the stone frag clearance rate was almost the same. Early results are very good, but at the 3 months, everything almost remains equal. So this is a long-term results. We need to find out which is better. Many people have a problem of not getting the stone sucked into the system. You need to see to assembly that anything is not blocked, and secondary is too much fast withdrawal of your scope. may lose the vacuum cleaner effect at the tip of the scope, and you will lose the vacuum cleaner effect and you will lose the stone. In that cases, you need to withdraw slowly, gradually till it comes to a wide limb. And this was a full assembly, that is where I use a flexible ureteral access seat, fans plus intrascope suction, so that the even a lower calysis, if I use this, it can be. And this picture was recently quoted by a webinar by women in urology. And still, over a period of time, what I have observed is removing the larger fragments and spending a lot of time in removing these larger fragments is ultimately is very tedious job, removing the scope for a 50 centimeter. So what I have now gradually is doing is I do like a standard RIRS. I do dusting. I try to do dusting as much as possible. And when there are few fragments which inevitably happens at the end of the surgery, I try to suck with the fan so that all negative pressure is inflow outflow is maintained. There is no very much high pressure in the PC system throughout the procedure, and at the end of the procedure, all small stones can be removed. And ultimately, it saves the time rather than fragmenting and coming out for 50 times. I thank you and I conclude my presentation here.
Thank you. Thank you very much for nice presentation. So we will stop sharing the screen. So let me ask few questions. You have covered most of it actually, not much this thing. Number one, what I am feeling nowadays is stent first for a high volume stone. High volume in the sense more than 1000 or more than 1.5 to 2 centimeter hard stone, and do suction RIRS, and then do stent. If you feel that there is no injury, put a guide wire or ureteric catheter and by evening. So in any urology procedure, stenting is done most of the times, except in PCNL, URSL or RIRS. So if you stent first, you can avoid stent. What is your comment?
Yes, sir. I do a lot of cases where I even if there is a, if I they're doing a primary RIS, even a first slighted resistance, I will stop. I will put a stent and come out and do a RIRS at the second stage. In second stage, most of the cases I am avoiding now stents. No stents, no Foley's catheter.
Because there is no much fragments left behind in the kidney, and you are seeing complete kidney cleared. Then there is no point putting the stent.
Yes, yes, sir. Yes, sir.
Second question. I am also trying RIRS with normal scope, make powder and last few fragments. Actually aim for a good powder and fine fragments, not large fragments by popcorn method. And fast fragmentation, fast popcorn, whatever the method you wanted to use. And by the time ureter gets dilated, a little bit of memory will be there, straightening of the will be there, and access sheath utility also will increase. So we are passing, you told very correctly that after 1 hour, you pass the access sheath and 10 minutes you suck out everything. Oh, luxury it is, luxury. So 9.5 French by 11.5 Cook I will use in the mid ureter, and the PUJ, everything gets passively dilated. Naturally, 45 minutes if you have done, then flexible. Even this maneuverability of the scope also will be better when you are painting. When you are sucking, maneuverability is not required. You can float them and then get back. My third question is, people are saying that TFL, the sticking nature of the stone is more when compared to homium. Of late, I have not done with homium any case, so I am not able to compare. But yes, any sticked powder or sticked fragments, you need to flush heavily to suck. What is your opinion? I am feeling uncomfortable to flush forcibly. After doing so many years, you don't like to pressure and create too much pressure to suck the fragments. It's actually underestimated problem of the fans. In the fans, if the person who is flushing is not good, he can collapse the system because of suction. He can overdo and unnecessarily causing a problem. This is one concern in fans. What do you say?
Yes, sir. The you said is very correctly that the TF. But sir, what I have observed is when you do a TFL and fans combine, you are sucking intermittently and all the powders is coming out. So the problem of the sticky small fragments or a powder in the pelvic elastic system is very less. If even if it is formed, what I do is I do just manipulate with the scope.
Yeah.
Just try to manipulate with the scope and try to I avoid active irrigation as far as possible,
Yes.
far as possible,
So
because
manipulate
whatever may be the suction pressure, we can increase the intrarenal pressure, and whole concept of IRP has gone wrong.
Yes.
In that case.
And as a matter of fact, I need your honest comment on intrascope suction, where 1 minute you raise the pressure and do the surgery, 1 minute you suck. So both will not happen, suction as well as this thing. So in that case, the harm of the raised intraperineal pressure cannot be reduced in intrascope suction.
So what has happened is, actually what I think is, we get the concept of intrascope suction very wrongly for a first week. I never flush it. I first aspirate and then just continuous irrigation for some time. Try to fill the PC system and then try to aspirate. These are the things. Never it is a first push and then suction. It is always first aspiration and then continuous irrigation. First thing. Second thing is, this concept was started when there was this suction ureteral access sheath or fence was not inciting at all. So at that time, even with this minor improvement in infection rate, stone clearance, better vision were very much important at that point of time. And I think that is why it has evolved. In 2013, when we started doing an RIRS in a better way, we all learned that there should be no negative pressure in PC system. We were afraid to do any suction in PC system for next 5 to 7 years. But then a intrascope suction, we developed a intrascope suction, and we see that it is not a concern. It is all about how negativity you create in the PC system. And so it has evolved to a manual intrascope suction, has forced the company to do a non-bendable access sheath and then a bendable access sheath cam. And we can see that the 1113 has now come to 1013, and if it at one day, as you are saying multiple times, that if we find a 6.3 scope and a 9.5 sheath, and that is also bendable, and with the suction, all the luxuries what we have will be double or a triple, or it may skyrocket. So the number of PCNL for a small stone is going to be significantly down. For a large stone, PCNL has a role and it will remain the stone gold standard.
One more question. If you use one French different, I don't want to mention the scope company. One French scope difference also recently I have done in a live conference. The amount of the suction effect of the powder was not there. There should be some gap. There should be some gap between the scope and the sheath, and that gap should not be a small gap. It should be good gap, not a very big gap. It's not possible to have very big gap like in PCNL. But 2 French, 3 French, if it is there, we can have luxury in sucking the powder in and there itself.
So there are studies coming out that inner diameter of sheath and outer diameter of the sheath, and the ratio of inner to outer diameter. And what we have seen is previously it was recommended to that if you do not want to raise the pressure, it should be at least 2.5 French difference between inner and outer sheath. Inner side of the sheath and outer side of the scope. Correct. Now it can be extended to a 0.85 ratio, but still, the smaller the scope and the smaller the sheath, the difference should be around about 2.5 French. If there is a 2.5 French difference, if you divide it by 3, your 0.8 mm stone can be sucked out. So up to 5 mm fragments should come out without any problem to scope or sheath or anything else. So there should be, smaller the scope, better the vision and better the suction.
Yeah. One more interesting question I want to ask. Why people are not able to reduce this 3.6 French channel further? Any scope you take, let it be 7, everybody is 3.4 or 3.6 French. If you can reduce that with 150 micron fiber, thulium fiber laser, water inflow will not be affected much. You don't require that much water flow. You can use a little bit of force. if we can reduce 3.4 to 3 French, the channel size, you can really make a difference in the size of the scope. Probably the 6.2 French new scope, which is coming from Poussin as well as the huge med, both they might have reduced the channel, the water channel. I have a feeling that in future that channel size also can decrease, and 150 micron fiber thulium fiber laser is a boon. I don't know whether you are using not. I'm using 150 micron. Very happy I am.
Yes, sir. 150 micron fiber have a very good inflow of the water. So ultimately, inflow outflow channel is maintained, and if the irrigation, even when you are using a smaller scopes, we have a 7.2, 7.5 French scopes, the 8 French scopes, and sometimes 8.5, 8.7 French scopes. If you are using a smaller scopes that are true 7.5, 150 micron fiber will have a very good irrigation, and even the suction only works when there is a good inflow. Only outflow, only suction will create a negative pressure, and there will be hemorrhage in PC system. So it's all inflow and outflow. So if you are 150 micron fiber, the irrigation will be better and suction will be effect will also be better.
Sooner we may come with tip monitors like temperature and pressure, not in less than 1 year. I think a lot of people are doing research work. And do you think we will be careful minute to minute? For example, when you are in ICU, blood pressure and pulse rate monitors will make the treatment better. If the BP is high, we give sodium nitroprusside. If it is low, we give noradrenaline. Like that, every minute to 5 minutes, if you see the pressure and temperature, you may not be aggressive in your water flow as well as continuous popcorn like that. What is your opinion?
Yes, sir. It actually we did not have a tire pressure monitoring or a temperature monitoring or a tire everything that all has come to our cars, and now our driving and everything has
much safer. Stuck, I think.
become more safe. Indicator you are changing the line. Same time, same thing will happen to our a real time monitoring of pressure. Whenever you do a surge pressure by doing an active irrigation or whatever by methods, then you will come to know that you are doing too much positive or too much negative pressure, and your overall surgical safety will increase. We need to match the success and safety of RIRS in relation to infective complications to PCNL. If we can match these infective complications, RIRS at a better age because of other factors.
Yeah. So another thing, what I'm thinking, in PCNL also suction is there. As compared to the RIRS, do you think that PCNL suction is more useful? I don't think so.
For a quiet period of time, initially I use a lot of suction in PCNL. Then I gradually shifted to non-suction and a standard PCNL by 2022 French and the 19 French. Still, I am using most of the cases. The PCNL is by 20 or 22 French plus, and there is hardly any significant praise difference. But what has I observed is we are now moving to a smaller and smaller scopes and the smaller tracks. So with the smaller tracks, we are actually having a tendency to increase the intrarenal pressure. So that cases it will come out. And the hydronephrotic kidneys. The mini perk was excellent, but whenever you find a large hydronephrotic kidney and if you do mini perk,
there Parimal, sorry to interrupt. Is it necessary to use 12 French for a small stone, less than 12 French suction pressure? Why not switch over to RIR? Still, large number of urologists argue, oh, PCNL is very easy. You just puncture, take it out, 12 French you use laser. I feel it is equal to RIRS. A lot of worry on the ureter about the stenting. You put stent before and later on you don't put it. So
Yes.
why puncture kidney and get into trouble? I mean, small stones, ultra mini perk, less than 12 French versus RIRS with fans with one stent before. I still feel RIRS with the fans one stent before will score in the future. What is your opinion?
Yes, sir. I am following same strategy that any obstructed infective system, small stones, I do put a stand, and I do not put a stand on them next time because of RRS
Yeah.
fans. So the patients are happy. Ultimately, it's just a reversal of the system. Primary surgery and stent removal. Now we are doing pre-stenting and the stent
And,
removal plus RIRS.
yes,
And,
yes.
and for
So it's
all the
no more a
possible,
three-stage procedure. No more a
yes,
three-stage
no
procedure.
more a three-step. Very few indications of third stage, third
Even
restenting.
in fact, if you make small powder and fragments in PCNL, the stone-free rate will come down.
Yes, sir.
We all do 22 by 18, beautiful. But anything 15 by 12, you will struggle and your vision will be less and you are not really happy. What big fragments will come through the 15 French, I doubt. I really doubt 5 mm stone can come. More than that will not come. More than that
Yeah,
will
if it is at 15, there is a maximum stone diameter will be 4 millimeter.
4 millimeters.
Yes.
That 4 millimeter, if you want to do 100 pieces, the beauty of PCNL will go. Some of the migration of fragments into, in RIRS, at least you can go to each calyx in no time. But in PCNL, it is not that easy.
For a small to medium sized stone, I think over a period of time, in with the evolution of fans and other parameters and the flexible ureteroscopy, number of PCNL for a small stone will definitely go down. For a
Actually,
large stone,
actually,
it is not.
when PCNL came, residual stones of PCNL, RIRS was indication. Now, RIRS failed cases, PCNL will be there in
Yes.
future. If you cannot do RIRS, then switch over to PCNL. Up to
We
1.5 centimeter, I think, I feel.
So it actually what has happened is what I think is it's an evolution. What we have all people who has learned the PCN in the last 20 years are more comfortable in doing PCNL and they are never afraid of doing a PCNL punctures. What has
Yeah.
happened is now the next 10, 15 years, most of the people we see more RRS and only complicated PCNLs, things will automatically get to going to reverse.
Yes.
Because for a
And
small
one
stone,
more thing I'm thinking after the RIRS with fans has come, I know you are repeatedly telling that I don't want to use pressure, but pumps, what happen? Pump at a very low pressure, they uniformly send some amount of water and uniformly you can suck the suction. So one additional person role will decrease. Do you do suction yourself or assistant will do? Usually
fingers.
my assistant will do the suction at the hole apparatus. Small
Yes.
hole will be there now. Assistant will be closing and doing. I don't do that.
Yes,
Uh,
I for me also assistant is doing. But what I have suggest to a one manufacturer and it has sent me one or two prototypes also, which has a sliding mechanism, sir.
hmm,
For closing the hole, just a sliding mechanism. So just
yeah.
slide and it will blow. So now it is now surgeon's control. I have tried in a few cases and I am happy that I am not more dependent on the assistant. An assistant is not coming in between surgeon and the patient.
Yeah, actually for me, 1 or 2 assistants are required for one flushing person, one suction person. I have luxury at the moment, but that much luxury juniors may not have it. So we have to look into this matter that whether low pressure pump irrigation still okay or not. Actually, it is not okay, but I still use 50 ml syringe by assistant. I don't use by gravity. Somehow gravity, lot of people are doing. Even Siddhalinga Swami in my hospital is doing by gravity. Do you use gravity or from 50 ml syringe?
No, sir. I use a gravity and I attach a 100 centimeter extension before the scope. And there is a 20 cc syringe at the extension. Whenever I require a slight pressure, it
So
will
that means you
5
are
or
using
10.
both
Yes,
gravity as well as 20 ml syringe with
90% of time it will be gravity for a few minutes, or when there is a instant collapse of PC system, the assistant
as
will
a
flush.
matter of fact, nowadays splitter Parimal means two-way tubes we are remembering. Your face is with two ways. So you use 2 ways. That is anyway good. Now, do you think the stone-free rate can match to 100% in near future with this type of fans?
A lot of paper are coming up which have done CT scan on post of day 1, and they are getting almost 100% stone free rate.
Yeah, that is a
Dr.
big,
Gohar
that
has
is a
done
big,
many
big, big.
many many cases, and there are papers coming from all over the world, sir. People,
Like,
it
that
is
will-
just that will see us actually the results on post-operative day 1.
That's a
And
game.
it should actually clear all the stones.
Correct. The recurrence rate will decrease. Metabolic patients will not form stones rapidly, and definitely. Do you advise bilateral RIRS by any means? Stent both sides and do both sides RIRS, especially with fans, because fever will not come.
Only
Patient will not pay more, no doubt.
Only when there is a stone volume is less.
Less.
Only when there is a stone volume. So
Nowadays,
what is the regional difference in the stone distribution? When I was in Ahmedabad, there were almost a large stones. When I am in Surat, we are finding a lot of number of upper ureteric stones or a small stones, and there are obstructing stones. That is why. So sometimes I do it, not always.
Yeah. How, for example, if any patient wants to go to abroad, upper ureteric stone, and you wanted to finish the case within 1 week, what are the extra tips and tricks you will follow? 1 week time is there, and he believes in you. He is ready to pay you. His stone volume is less. He says next week, same day, I wanted to go to US.
Sir,
First, I never used to do it.
Sir, I will not touch that patient.
You will not do it. What I am doing is
at least 15 days time is required, sir. At least 15 to 17 days time. Stent removal, and at least 5 days after the stent removal, patient has to be in and around the urologist hospital, so that any complication or infective complication after stent removal can be handled well.
It's a very good answer. Very good answer. I must tell you. Let us stick on to it. I don't want to open my mouth. I will also say that give me 15 days time, postpone the ticket. Life is more important. In the airport, if he gets chills and rigors, by the time he reaches the US, if he goes into hypotension, it is a mortality morbidity range case. So nobody can give guarantee to him. We cannot get IV antibiotics the way we get in India. So it's a disaster. So
Yes,
I feel RIRS needs minimum 15 days of stay with you, 12 days plus 3 days. Antibiotics is not the answer. The natural problem is the answer. Whether you do suction, whether you don't do suction, that's a different.
Yes.
Very nice discussion. You are very mature now this time when compared to 5 years back. Great. And I hope you expand your knowledge and go to the all fields and do research. And let us also, if possible, write up some paper from India. A lot of people, you, myself, Vikram, a lot of people are doing Delhi, Tanuj Paul, but they are doing access sheet with suction. It's an early phase. Another 1 or 2 years, it will be a hot topic. After that, everybody will use I have feeling. Chalo, very good. Thank you very much for nice presentation.